This is Dr. Rick Lehman with In Your Corner with CORA. This is part 2 of August 12th, 2020. And in part 1, we talked about the anterior approach, the posterior approach, indications, and the rehab. And we're going to talk a little bit more about the approach, but we're also going to talk about questions patients would ask the doctor, i.e., what can I do on my new total hip? What can I expect in terms of longevity? What are the incidence of any type of complications? What's the incidence of infection? So jumping right in, and this has been awesome. First, I'm going to start with you, Dr. Maylack. According to the literature and your experience, what are the complications? And let's talk about complications, not so much hip dislocations, but complications like infection, wound issues, loosening, etc. And then after that, let's talk about what can I do after I've got my brand new total hip.
Perfect. Yeah. Well, you know, you have to understand for patients that when you have surgery, there's always risks. Starting with the anesthetics. You know, the anesthetics have become very, very safe. We always tell them it's safer than driving your car to come to the hospital, but it's still a risk. And although it's almost infinitesimal, but certainly there's risk from anesthesia. Second risk, when you're having surgery, there's always a risk of bleeding and loss of blood and need of blood transfusions. Very, very rare now. We're able to do Jehovah's Witnesses without worrying about transfusions, but there's always that risk for patients about needing blood and blood transfusions. So the perioperative risks, you know, anesthesia, blood loss. Then you start to get out a little bit from the surgery and you have that risk of infection. And as I always tell people, orthopedics would be very easy if we didn't have to deal with infections. And infections in a total joint are catastrophic. And so we go to great lengths to try to prevent it, giving from the preoperative things, nutritional support, cleaning, hygiene, intraoperative things, wearing hoods and spacesuits and having laminar flow rooms, giving people antibiotics, and post-op wound care. We have all sorts of special bandages and dressings now so people's wounds are sealed so they don't have the risk of getting contaminated by either themselves, family, nurses. But those are certainly is still a huge risk of those things. Anesthesia, blood loss, infection, and then as you start to get down the line, the risk that we would talk about in this lecture about anterior and posterior is the risk of dislocation. That's one of the major potential risks of a hip replacement. It comes out of the socket. The ball and socket, it floats. People think that they're unlike a knee where there's more constraint. The hip can come out of the socket. We take it out of the socket to put a new hip in. And so that area, whether it's from the front or the back, there's sutures, there's repair. And so what we find is as the therapist we're talking, patients are so pain-free these days, no matter what the approach is. We find we're having to slow them down. Not, you know, in the old days, it was to push them to get going, get out of bed, get moving, let's go. Now we're trying to slow them down for that first month because we just want the tissues to heal, the incisions to heal so we don't get infections, the deep stitches to heal. So for the first month, we kind of like to keep them under wraps, don't overdo it to prevent those complications. But certainly, although they're very rare, I think that they're after 6-8 weeks, it seems to be the complication rates with anterior and posterior are very similar. But I think there is no question that there's a slightly higher risk of hip dislocation in a posterior lateral approach than an anterior approach. And I think that's why so many young surgeons are learning that anterior approach so they don't have that risk of dislocation.
Dr. Hamilton, I'll throw the same question to you, and then tell me, and I'm going to ask Dr. Maylack the same question. I got my new total hip. I'm so excited. I want to go out and play one-on-one basketball. What sports can I play, and what sports can I play with my new total hip?
You know, I think I agree with everything he said with respect to, you know, the initial complications. You know, down the road you start to worry about wear of the plastic liner or the polyethylene, which we're not really seeing as much anymore. And I think they started using new polyethylenes about 18 years ago, and they're showing very minimal wear now, which means we don't have as much associated osteolysis, which can cause loosening of the components. So right now, we think we have a pretty good survival rate at about 18 to 20 years, above 90%. Pending these other things that he mentioned don't happen, such as infection, recurrent dislocation. And a lot of that has to do with either patient's anatomy. We're learning a lot about spinal pelvic anatomy and how that kind of correlates with hip stability. And everybody is pretty unique. We don't have the safe zone anymore that we used to think we had. Now that aside from loosening, everything else he said was, I think I don't really mention anything different to my patients. So as far as what to do, I think this is probably very surgeon dependent. I want to slow them down also for 4 to 6 weeks, specifically just to allow the soft tissue to heal and let the bone start to ingrow into the prosthesis to help with stability there. And then my biggest thing is I'd say don't pick up anything new. So if you like to ride your bike, ride your bike. If you know how to snow ski and you're comfortable snow skiing, you can get back to snow skiing once this is all over. If you want to play golf, play golf. But don't pick up any new extreme sports. Don't pick up any new real kind of aggressive activities that you could potentially hurt yourself with. And that's just, we're putting hips in younger patients now. I did one in a 38-year-old today because he had avascular necrosis and collapse of his hip. And I can't really tell him he needs to be, on a treadmill for the rest of his life. I guess I could, but that's not my goal. My goal is to let him get back and do the things he enjoys doing. And so my biggest thing is don't pick up anything new extreme, anything new aggressive, but if it's something you're comfortable with and good at, after the 3-month period, you can start easing back into it.
That's awesome. Dr. Maylack, so same question. What's your incidence of loosening? Is that about right? You're going to get 15 years or that's what the patients ask me, if I get my hip replaced or my knee replaced, how long is this thing going to last? That's the first question. And then the second question is, can I get back to tennis or can I get back to golf or can I run? So how do you counsel your patients?
Well, I'm like Dr. Hamilton. I agree completely. The hip technology has gotten so good. It's really a pleasure. When in the old days, and maybe we should explain how that when we put a hip in, it's a metal component. There's sort of 2 ways that it's bonded to the bone. One way is to use an epoxy glue. But the problem with those glues is that after like a filling in your tooth, after 10, 15, 20 years, the glue gets dry and cracks and your filling gets loose and your dentist has to put a new filling in. In the old days, we used glue on hips. And after 10 or 15 years, that glue would crack and get loose and the hip would get loose and they'd hurt and we'd have to go back in and do new surgery. So they invented this technology where there's a special surface on the bone like a Brillo pad and the bone grows into the metal and locks onto it and becomes a permanent part of you. And as Dr. Hamlin was saying, when we use this ingrowth technology after that first 4 to 6 weeks when the bone is grown into the hip, we're very confident letting people be aggressive with sports and recreation and activity. We just don't see loosening anymore with even guys who are very active in sports. The one thing, and Dr. Hamilton mentioned, is that at the articulation where the ball and socket meet, we've tried different kind of technologies, and we still use a metal or a ceramic on plastic technology. The metal on metal technologies did not work. And so there's always a fear that like anything made out of plastic, it's going to fail. The metals typically never fail. They'll probably last 1,000 years. But like the plastic in your refrigerator or your car, those will fail eventually. The plastics in hips have gotten really good. And so we don't really see failure at these things in 15, 20 years anymore. And so we're starting to say, well, these things might last 30 and 40 years. We don't know with this technology. That's our hope, that people can stay active, be engaged in their sports. The one thing I do try to counsel is I try to keep people fit. If they get heavy, they get overweight, that will put more load on the hip. And so I do advise people, if they're going to be active in sports, they need to keep their weight down to try to minimize the loads on that joint. But like Dr. Hamilton, I'm pretty comfortable letting my patients be aggressive once they've gotten through that early window of 4 to 6 weeks.
So do you think, both you guys, do you think your incidence of liner replacements has gone down in the last 10 years? Well, Dr. Hamilton hasn't been out as long, but.
On that way. A lot.
Yeah.
But what
Completely. Yeah. I hardly see wear on those things anymore.
I trained at in residency and trained in Manhattan for fellowship and had a large variety of patient population from the indigent to the really wealthy. And some of these people had hips in forever. And rarely would I see somebody who had a hip placed after, 2002, 2003 come in with liner issues. It was always somebody in the mid 90s or something along those lines where we were needing to revise because of eccentric wear or something like that.
So let me ask you that again, Dr. Hamilton. So you're in your training, you're looking at your revisions. What leads to revision? What leads to loosening? What happens?
I'll say my revisions right now in practice, I get a lot of them since I'm the new guy. Most of it's fracture or infection. There is some of these patients that my partners have taken care of for many years, and they tend to take care of their own revisions. And I've seen some of their, osteolysis around the acetabulum because they had maybe an older type polyethylene. And so they've had some bone loss there. But as far as stuff that comes into my clinic, it's mostly that's infection, and then stuff through the ER is usually periprosthetic fractures that I'm revising.
Wow, that's really, and it's informative because it's good information. I'm a sports guy to tell patients because that's their biggest fear. Well, I'm 50, I can't walk. Like Dr. Maylack said, I've gained weight. My life is just terrible. But if I get a total hip, I'm going to have 2 or 3 total hips. And to be able to say, look, this may last the rest of your life, I think is a lot more optimistic than saying, look, it's like a set of tires. You're going to get your 50,000 miles and then you're back at Firestone getting some new ones. So I think that's extremely informative. So let's kind of move on just a little bit. And we talked about it. And I want to ask both you guys what the strengths are the posterior approach, strengths are the anterior approach. Is it a personal preference? Is it a maturation? More people are going to anterior because of dislocation. More people are going to anterior because of robotics. Or is it regional? I know a lot of the surgeons here in St. Louis still go posterior and are very satisfied. And the totals that I see when I'm taking care of their Achilles tendon or whatever seem to be almost indestructible. And these people are skiing, they're playing tennis, some of them are playing basketball. So it's pretty aggressive. So I'll start with you, Dr. Hamilton. Give me the strengths of the anterior approach. And is it just training and personal, or where's this going?
I trained in both, and I made the choice when I came into practice to do anterior approach, and it was strictly for the first probably 2-week post-operative period. As a resident and a fellow, I rounded on my attendings who, some would do posterior, some would do anterior, and I got the sense that pain control was better with an anterior approach. And I think that ultimately, though, it is a personal preference. It's the one you ultimately have the most confidence in yourself to place a hip in the appropriate position to maintain stability and longevity. Because at 6 weeks, there's no study that would say any approach is better than the other. And ultimately, that's all that matters. I do think for me, in my hands, I have less blood loss with an anterior approach as well. But with TXA, I don't think blood loss is really that much of an issue anymore. And then obviously stability is nice, but Dr. Maylack doesn't walk out of the room with an unstable hip. I'm pretty confident, he checks stability. So, that is something with the posterior capsule repair. I think recent studies have certainly questioned whether or not there's a difference in dislocation rates. I think ultimately it depends on component position, which ultimately depends on surgeon confidence in the approach they're doing.
Dr. Maylack, give us your best shot here on personal preference. It sounds like obesity might be the one contraindication. Somebody who's got an accentuated BMI. I know you guys don't like really to operate on people with accentuated BMIs, 50, 55, where clearly those people have sore hips. But other than that, give us a little insight into posterior approach, training, personal preference. What are the positives?
Yeah. I think the main thing is surgeon experience. And that's sort of what we're finding in hips and knees. There's certainly a bell curve. And if surgeons do a lot of hips or a lot of knees and they know what they're doing, the results are probably going to be better than a surgeon who does a few here and there and experiments with going one way one time, another way a different way. And I think that's the only advice I tell patients, to be a little careful. Make sure your surgeon has done enough of them and is comfortable with the anatomy and the structures. And I think that's where it's not so much personal preference, but it's sort of personal experience. You want your surgeon to have an experience that matches what you need, and so that your hips has the best chance of turning out long run the best.
Thank you. So I'm going to ask both Katie and Ash one more question, and then let anybody fill in where they want to fill in. So a patient comes in, they're a year out of a total hip, really haven't had a whole lot of complications. Tell me about gait mechanics. Tell me about strength. Will they have a deficit at a year? What does the total hip look like at a year?
Should be pretty solid in a year.
Because they were usually not seeing them at a year because they're doing really, really well and they're no longer having pain.
Well, then I'll turn that question over to the two doctors. You get an X-ray at a year, gait mechanics, strength deficits. Where are they at a year?
Well, let me jump in. Yeah, I think people even before a year, at first, after 3 months, people are really doing really well, and you're not going to see much weakness anymore. Not like in the 90s when you would tend to see weakness that even with a limping gait or that could last up to a year. But nowadays, after 3 months, we rarely see that anymore. People's leg lengths are good and their gaits are good, and they're really typically cruising at 3 months.
Yeah, I agree. I think at 1 year, the hip is one of the joints that you replace and they forget they've had replaced. The knee, they'll never say that. But I think really at 1 year, I know that Katie hopefully is not seeing any of my patients at 1 year.
I haven't so far.
I'd be sad if she's seeing them past 3 months, to be honest. I think, they're, usually by their I see mine at 2 weeks and 6 weeks. By 6 weeks, if they have contralateral hip pain, they're ready to move forward with the other hip, often begging me to do it. And so, with the hip, they forget it. It's been replaced.
That's awesome. Does anybody have anything they want to add therapy-wise? Anything we missed?
We're seeing more patients pre-op, and I think that makes their post-op even quicker.
Okay. So prehab is a good thing to do if you're going to go get your hip replaced.
Yeah,
Absolutely.
I send all mine to Katie beforehand.
Yeah, we've been doing that for several years, and I think it's really beneficial in several different aspects. I think one of the biggest things is kind of like we talked about a little bit earlier, is managing those expectations. I think if you can kind of go ahead and let the patients know what they can expect after surgery as far as their overall recovery process is going to look like, it helps them afterwards too. This is something that we see day in and day out, but our patients obviously don't have this every day. So a lot of times I find that things that seem really normal to us may not seem very normal to the patients. And so kind of giving them those expectations in the prehab type of environment, I think is really beneficial, along with strengthening up support muscles and things that they'll need after surgery. And honestly, a lot of the exercises that we do beforehand are also exercises that they're going to be doing afterwards. So it helps kind of build that muscle memory for them as well.
Listen, you guys have been awesome, and I really appreciate it. CORA appreciates it. And I want to thank everybody. This was very informative.